Right, good evening everybody, and thank you to Honky and to Brad for the invitation, and it's always a privilege and a pleasure for me to talk about the elbow, which is a bit of a passion of mine. And thanks Ponks for the introduction. Just to let you know, I'm a director of one of the directors of Bell, Rogers and Harris, along with Suzanne Rogers and Lindsay Harris, who are here. I'm also a director of Off Nickel with Lindsay. And involved in groovy movements as well. So our Bell, Rogers and Harris team are here this evening. So thanks guys for coming and the support. And Brad asked me to talk about principles of physiotherapy, and I thought, flip, that's like talking about the short history of nearly everything. So we're going to do that about the elbow, not specifically on tennis elbow, but I have published a new article on the principles of management of tennis elbow for 2018. And if you would like that download, it's a free download of this website. And for those of you who are interested in learning more from the physio side on the elbow, you can get hold of Bronwyn Henshey at this email address here. And we'll be running a 2-day, an evening course to make up 8 hours on these 2 dates here. So if anyone's interested in doing the elbow before the end of the year, this is the last go. So when we talk about the elbow, I'd like to use this opportunity to throw in some of the new research that's coming out at the moment and the principles of 2018. And one of the things we look at is the principle now from Sackett of 2000 called evidence-based practice. And that means that effectively as clinicians we need, and it's a multidisciplinary approach, we need to take the best available clinical evidence, so in the best research, but we have to combine it with our own ability to cognitively and conscientiously make decisions dependent on the patient values and expectations. So our management of patients is dynamic and changing according to what we see with the patient. So what can the physio contribute to the elbow? And I had to think about this, and I put these together. And the first one is, for me, a functional and clinically applied knowledge of the elbow 3-joint complex and its associated anatomy. And the elbow is a really complex joint. It's a 3-joint complex within one capsule. It's a highly constrained synovial hinge joint that is prone to stiffness far more than instability after injury because it is so complex. And to help us assess and manage the elbow, we need to be cognitive of a whole lot of anatomical principles. And to highlight a couple of these, some of the passive stabilities that are unique to the elbow, of course, would be the annular ligament and the interosseous ligament. And managing and understanding passive stability of this joint is pivotal and cannot be cut and pasted from, example, the hip or the knee or the lumbar spine. Similarly, we can apply the principles of abdominal canister or core to the elbow, where we look at things such as one-joint stability, and we look at the muscles that are close to the axis of movement at the elbow joint and its 3-joint complex, and we need to know about the principles and functions of muscles such as brachialis and coneus, supinator, and pronator teres. Then we need to understand the outer unit anatomical muscles, such as the biceps and triceps. And these muscles function as force couples to co-contract and give you dynamic stability during loading of the elbow. And again, this knowledge is important when we manage our rehabilitation principles. The next thing we need to know is a knowledge and an understanding of structures both at the elbow as well as distant from the elbow that could contribute to the patient's symptoms. And this is by no means a complete list, but it's to show you that, and I always say this, not everything is tennis elbow or golfer's elbow. And so many things are missed or misdiagnosed because of not understanding what the other structures that could be around the elbow from a pathology. And not only do we need to know what structures could be implicated at the elbow, but what are the stuff distal to the elbow that could be implicated. And these fascial links can highlight the myofascial relationship between the thoracic and the shoulder and the elbow and the wrist. So this is a dissection where the fascia is still intact. And this is lower, middle, and upper trapezius linking with anterior, middle, and posterior deltoid, coming down into the lateral intermuscular septum, and then linking to the wrist extensor mass and down to the wrist, showing you the relationship between thoracic spine and lower limb and upper limb distally. And it also very similar to the upper limb tension test 2B position, which is the radial nerve distribution. Similarly, if we look anteriorly, this is the clavipectoral fascia linking to the pec minor, coming into the biceps and coracobrachialis, into the forearm flexors, and replicating the median nerve distribution or the upper limb tension test distribution, showing how the fascia can be implicated in your elbow pathology patients. And there's a lot of research coming out at the moment on serratus anterior and middle and lower trapezius and their linkage into elbow pathology. So for example, fatigue of scapular stabilizers can predispose to elbow injuries in throwers. This study showing decreased strength of serratus anterior and so on, and change in muscle thickness in patients with LE, and LE stands for lateral epicondylation or tennis elbow. And here, modifying scapular position modifies the position of the humerus and is reducing lateral elbow or lateral tennis elbow symptoms and improving grip strength in this group of patients, showing the link that we need to be cognitive of thoracic and spine and scapula. What about the link of implicating glenohumeral pathology to elbow pathology? So if you, for example, have a loss of glenohumeral lateral rotation range of motion, and you are a thrower or a server, that can force a compensatory give of supination or valgus at the elbow, linking glenohumeral pathology to elbow pathology. Similarly, a loss of glenohumeral medial rotation range of motion, or a GERD, can force a compensatory increase in forearm pronation, for example, in the double-handed backhand. I don't need to tell you about the importance of the nervous system and how that integrates and relates the whole system. What about cervical spine involvement? How does the cervical spine can cause lateral elbow pain? And for example, full elevation of one arm, so repetitive throwing, repetitive serving, repetitive volleyball position, causes a repetitive bombardment, resulting in traumatic tears of the disc and hypermobility of the facets, resulting in pathology at C5, 6, and 6, 7. That can cause peripheral neuropathology, a neurogenic inflammation, which refers to the elbow causing damage to the neural structures and surrounding tissues, so that the patient can present to your rooms with lateral forearm pain and elbow pain. So much research currently is on central sensitization, and not only for recurrent back pain, but also for persistent and recurrent elbow pathology and pain. And for example, this study found that in females that had had tennis elbow for more than 6 months, they found that when they looked at pain pressure thresholds at the elbow, there was a reduction in pain pressure threshold not only on the affected arm, but also on the unaffected arm. Similarly, they found that there was a significant reduction in pain pressure threshold. So these patients were more pain sensitive or hyperalgesic, not only at the elbow, but at C5, 6 facet joint bilaterally. And this was implying that these sustained pain or noxious inputs from the elbow to the central nervous system can start and maintain the central sensitization or hyperalgesia. Some fantastic work currently has been done on thermal hyperalgesia. And what they've found, initially the research started with whiplash-associated disorder, is that if you have cold hyperalgesia, it's a very good indicator that you have a central sensitization mechanism as an association to your pathology. Now, if you apply a cold application for an ice pack, frozen ice pack, to your patient's elbow for 10 seconds, that patient should be able to handle that 10-second application and report a pain intensity of less than 5 out of 10. If your patient reports a pain intensity of greater than 5 out of 10 after a 10-second application, there is currently on evidence a 90% likelihood that that patient has cold hyperalgesia. And that is indicating at the currently of poorer recovery to your management strategies, and that their quality of life is significantly poorer. So it's a very nice objective measure that's currently being used to help you, assist you with this central sensitization component. Other central components that we need to be aware of is fear of movement or injury is identified as a predictor of acute and chronic musculoskeletal pain. Depression commonly occurs with chronic pain and can negatively affect your prognosis and your recovery, even in elbows. And higher levels of anxiety and depression are associated with increase in pain levels and disability. So these are areas of research that are currently being applied also to the elbow patients, and it's really interesting work. So the next thing I think that the physio can contribute to the management of these patients is a comprehensive patient interview and an objective assessment of the elbow and all the contributing factors and comorbidities. So we use a detailed elbow assessment, so it's specific for the elbow patients. And they should be applied, they should be treated as a unique subgroup, not just given a generic assessment, I feel. And other comorbidities that we look for: are they a smoker? Do they have diabetes, gout, hypothyroidism, hypertension? What is their nutrition like? What is their sleep hygiene like, and their stress management? And these are associated factors that you should, that I feel that we should be assessing. Imaging is obviously very helpful, but it's just important to visualize different pathologies, and MRI arthrography, excuse me, too many words, useful to pick up other pathologies. But the severity of the pathophysiology is not often related to the pain and the function. And often 50% of the ultrasounds, for example, have false positive. So as physios, there's no evidence on findings of imaging that imaging should dictate management or be used as an outcome measure. So we need to treat patients according to their clinical symptoms, not be told that they have tennis elbow and we must now simply treat the tendon. We need to assess each patient on their management or on their merit. A negative ultrasound can rule out tendon pathology. So a negative finding can be very helpful when you're assessing your patients. And recent information is suggesting that if on ultrasound, for example in tennis elbow, a lateral collateral ligament tear is found, that may explain a non-resolving lateral elbow pain. We now use a patient-related tennis elbow evaluation sheet. And this is extremely useful. And you can get this as a free download anywhere online. And we now routinely ask our patients to fill this in when they come in at their first assessment, and then they refill it in every 2 weeks. And this is a very nice objective patient-related scale to give you an indication of if you're improving the patient or not. Brad asked me to mention red flags, and again, not everything is tennis elbow. And if you have children and adolescents with lateral elbow pain, surely that is a red flag. And this is an example of osteochondritis dissecans. And these patients, these adolescents who are normally involved in sport, are presenting with lateral elbow pain that if a detailed assessment is not conducted, you could potentially miss this serious pathology. Other red flags, of course, constant pain, persistent swelling. But the biggest red flag is that they're not responding to the treatment. So the biggest red flag is that with your management, the patient is simply not responding. So red flags should not be assessed and ticked off at the first assessment, but they should be constantly reevaluated to make sure that we are correctly managing a musculoskeletal mechanical problem. The physio's objective examination is incredibly detailed. So we start off with the PRTE questionnaire. Our local assessment includes obviously active passive movements, isometrics, ligament stress tests. I use the grip dynamometer and I compare maximum grip strength to pain-free grip. The manual examination is very thorough and involves complete isolation of the three-joint complex so that we differentiate radiohumeral, ulnohumeral, and superior radioulnar joints. I use a tap test and I now add in thermal hyperalgesia. So I apply the cold ice pack to the patient's elbow and assess for the central sensitization. Our cervical spine assessment must include a manual examination of the cervical spine, the thoracic, and a palpation of the first rib. Our neurological examination must be detailed, including reflexes and a neurodynamic test. For the shoulder, we look at scapular control, and I look at my glenohumeral, medial, and lateral rotation range of motions. So which comes first, the chicken or the egg? And most patients will present with a combination of various contributing factors. So some will have postural influences. Maybe there's a local soft tissue tendinopathy, articular derangements locally and distally, cervicothoracic dysfunctions, glenohumeral rotational dysfunctions, and our anxiety, depression, passive coping skills, catastrophization, and so on. So what else can the physio contribute? So a multi-structural pathology, which is really what we're often looking at, requires a multimodal treatment approach. And as physios, we need to be up to date with current research. So I wanted to, there's no time to discuss all the different treatments, but just to show you with discussing corticosteroids. And this study looked at the effect of steroid injection versus a placebo injection, either alone or in combination with physiotherapy for tennis elbow over a 1 year period. And a single cortisone injection gives you a beneficial short-term effect, but much poorer long-term outcomes and a higher recurrence rate compared even to a placebo injection or to physiotherapy, and even worse outcomes compared to wait and see. And wait and see is basically saying to the patient, most of you resolve in a year, so don't shake hands, don't pick up heavy objects, and let's wait and see. So compared to an 8-week program of a multimodal physio application, which was a mobilization with movement and exercise, and they had the lowest recurrence rates significantly and almost a 100% complete recovery at 1 year. And they were much better in the short term in that patients required fewer non-steroidals or other medication to assist. A combination of cortisone and physio resulted in no better outcomes. And the conclusion from this study and multiple studies is that cortisone for tennis elbow is not recommended. There's another study looked at the cost effectiveness of the corticosteroid injection versus physiotherapy and the combination of these interventions compared to a blinded placebo injection group. And physio was found to be more costly in the short term, but more cost effective in the long term with better significant outcomes relative to placebo. Corticosteroid injection had greater variability and a lower probability of being cost effective. And Dinos and I once discussed doing a study looking at the combination of corticosteroid injection to physio, and this was found to be ineffective and cost ineffective, with the conclusion that physiotherapy and not corticosteroid injection should be considered as a first-line intervention for tennis elbow. This is in PRESS, the study, and it's quite interesting because they're using isometric exercise versus wait and see in patients with unilateral tennis elbow. And what's interesting about their study is they're looking at different objective outcome measures. They're using a global rate of change, which is a patient lifestyle rating scale. The questionnaire talked about pain-free grip, thermal pain threshold, and pain pressure threshold. And they found that the isometric group, after 8 weeks of exercises, had a lower PRTEE score, but otherwise there were no significant differences found between the two groups, concluding that exercise alone may be insufficient to improve global rate of change and have no effect on central sensitization. So it's implying in the early stages that as beneficial as exercise is, it needs to be done in conjunction with other structures. Now, one of the things Dinos and I have also discussed at length is in the lower quarter, it's okay to take the patient to a 4 out of 10 or a 5 out of 10 pain for some persistent tendinopathy, so for Achilles tendinopathy, patella tendinopathy. But we're just not getting the same effect at the elbow, and this is starting to come up in various studies. So first of all, the upper quarter, so including the glenohumeral joint, simply does not respond to the same loading as the lower quarter. And treatment and into pain at the elbow, without a doubt, seems to flare elbow symptoms. So this study from Coombs has found that if we do the rehab, starting with isometrics at the elbow, it should be below pain threshold to reduce symptom flares, and then we can progress to concentric and eccentric programs when the symptoms become less irritable. But across the board, it would seem that our management of elbows must be below pain threshold. And that can often be a pivotal component into getting the best outcome. When we look at management of patients using physiotherapy, there's a lot of discord internationally on how we manage. And symptom modification is the one thing that everyone agrees on, is we want to find the pain and change the pain. We want to find the stiffness and change the stiffness. And we want to improve outcomes by changing symptoms. And so there's lots of ways we can do this at the elbow, but a few examples: we can do mobilizations with movement, where we allow the impaired joint to move freely without pain, which is obviously a very specific manual therapy skill. We can do postural change, so we can change the kyphosis and see if the grip strength improves. we can apply counterforce bracing and change the pain response with wrist extensor activity. We can perform isometric exercises, which in the lower quarter in particular, by Ebony Rio and her team, which works with Jill Cook, have found hypoalgesic effects of isometric exercise that cause central pain inhibitory responses, and there's a lot of current research being done on that. And we want to do CBT, or cognitive behavioral therapy, to change the patient's behavior to the pain and change the belief that movement is painful so that we facilitate inhibitory learning responses. So there are bits, don't get panicked, turn around, here we go. So these are just some variable examples of mobilizations with movements where we effectively, for example, do a posterior glide of the radius on the stabilized humerus to increase extension range of motion. To increase pronation range of motion, we could do an anterior glide of the radius on the stabilized humerus, so that we are using pain-free techniques to create better range of motion in our stiff elbows or post-fracture elbows. In our treatment, I use this that I call the grid, and I really can't urge it. This has been a really effective tool for me. And so with our patients, all the objective measurements that I have are on the horizontal axis here. Then every single treatment is dated, and then if I'm testing pain-free grip with the dynamometer, what is my measurement before treatment and after treatment? And then I can compare my outcome measures within a treatment as well as between treatments, so that I can assess to make sure that I'm getting a successful outcome with my patient. And if I'm stagnating, I need to reassess and find out why. So the next thing we need to do is develop a management plan, once we've done our assessment, that is individually prescriptive to the patient and requires their active participation in treatment and rehabilitation. So it's not a passive management at all. And some of the management things we do, for example, when we're looking at rehabilitation, is looking at how we can best affect loading at the elbow. And there's been some fantastic work by Tom Goom, again on the lower quarter, where he found that heavy, slow resistance exercise programs have a far better effect, or a similar effect on the tendon over eccentric training with better compliance. And so we're starting to try and apply these heavy, slow resistance principles to the upper quarter. This elbow study here found that Stasinopoulos found that eccentric concentric training combined with isometric contraction had the best effect on tennis elbow. Remembering that your wrist extensors actually have an isometric role while you perform your hand movements. So we want to look at an isometric hold while we combine with concentric eccentric training, and that had very good outcomes. Again, progression of loading has to be sub-threshold of pain, and we do not hurt the patient during and no pain post. Minimum required manual therapy and loaded physio 8 to 12 weeks post-injury. These are some of the examples coming from the Groovy website, the Groovy app. So here we're just obviously doing wrist extension and flexion, concentrically and eccentrically. And these are the various isometric programs now, where we start with a flexed elbow in a neutral position, and the isometrics are now held not for 10 seconds, but up to 35 to 60 seconds sub-threshold of pain. And as the patient improves, we increase the loading, either by increasing the pronation or extending the elbow, and ultimately by adding an isotonic component to the isometric contraction of the wrist extensor mass. We can also progress to getting closed chain activity that brings in scapular glenohumeral loading. And again, using 4-point kneeling and other exercises to bring in progressive loading, to bring in the force couples that I mentioned to get that dynamic stability across the elbow. And finally, to summarize, passive treatments of the elbow in isolation have no effect on the motor cortex. And multiple studies show that it's a multimodal approach that has best outcomes in the management of many conditions, including those at the elbow. And I think this is something I've learned as I'm getting slowly older, but that is that we need to know as clinicians what our limitations are. So often with patients, especially post-trauma or fractures, we cannot effect a cure. We cannot say to the patient, I'm going to get you full 100% range of motion. So we need to understand our anatomy and our pathology so we can say to the patient, what are we requiring and what we can hope we can achieve. So that sometimes we don't want to effect a cure, but we want to give them a management strategy that improves their limitations so that their quality of life improves. And perhaps as clinicians, and not just physios, if we can avoid making unrealistic promises to our patients, perhaps we can prevent our burnout, which often happens around October and November, and our work stress by trying to achieve improbable goals. Thank you very much.